So now that you've seen the importance of elevated blood pressure and the complications it has caused, you should know how to measure blood pressure accurately. Now, measurement of blood pressure has numerous steps. Okay, so one very important thing before you measure the blood pressure is to explain what you're going to do. Okay, the technique should be explained to the patient. Ideally, the patient should be resting for about 5 minutes before you measure the blood pressure. If they are smoking or had caffeine within the last 38 minutes, that can increase the blood pressure reading. After comfortably resting in a chair with back support for at least 5 minutes is the ideal time to measure the blood pressure. You would want to ask the patient to keep his arm outstretched onto your table. You want the arm supported. Okay, the patient should not be holding his or her arm out like this, because that will again increase the blood pressure. So you should ask the patient to keep the arm on your table so that it is well supported before you attach the blood pressure cuff. Now, this is the common blood pressure cuff that we use. Remember, the cuff will vary according to the diameter of your patient's arm, and I'll be giving you a link to various cuff diameters, cuff circumference, and the patient's diameter of the arm, right? So whenever you're going to do this, you should make sure that the cuff is placed in such a way that the bladder or the inflatable part of the cuff comes over the brachial artery. It is ideally done on bare skin. So you should ideally ask the patient to take off the clothing or expose the upper arm. Now, if it is a tight shirt, do not roll it up, because that will create a tourniquet effect. So if it is a very loose, thin cloth, you can actually let it be rather than asking the patient to roll up the sleeve. Okay. So once that is done, once you have applied the cuff over the patient's arm, you now have to measure the blood pressure by first the palpatory method. So as you first you inflate the cuff, it goes around. You need to increase it based on palpation of the radial artery. So you increase the pressure in the cuff to at least 20 to 30 millimeters after the radial pulse disappears. One of the reasons we do this is to prevent missing out on what is called the auscultatory gap. Once you're very clear cut that yes, the systolic blood pressure is, let's say, around 130, I would then deflate the cuff and reinflate it, this time using a stethoscope which I place over the brachial artery. So now you're going to hear the sounds over the brachial artery and not palpate the radial artery. So first you do the palpatory method. Once you're clear, yes, this is the systolic, go 20 to 30 millimeters above that. So again, you're going to inflate the cuff, go 20 to 30 millimeters above what you palpated as the systolic in the radial artery, and now gradually deflate the cuff at 2 to 3 millimeters of mercury every second. As you're deflating the cuff, you will start hearing what are called the Korotkov sounds, right? So let's discuss these Korotkov sounds. Korotkov sounds are produced by the flow of blood through the brachial artery. So as you're deflating the cuff and you reach the highest pressure, you hear the first phase of the Korotkov sounds, or the first Korotkov sound, which is a sharp tapping sound which goes like tuck 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 tuck. This is taken as the systolic blood pressure. After that, this tapping sound becomes softer and gets a swishing quality. It sounds something like tuss, 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 tuss. Then the tapping sound returns, tuck, 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 tuck. Remember, all the while you are reducing the pressure at 2 millimeters per second. Then you go on to phase 4, when you will hear a muffling of that sounds. That is, the phase 1 and phase 3 tuck 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 sounds will now become tub 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 tub. And finally you will go to phase 5, when the sounds completely disappear. So for concerning us, The most important phases are phase 1, which is taken as systolic, that is the sharp tapping, the first onset of sounds, and phase 5, that is when the sounds disappear, it is taken as the diastolic, right? So now that you know the Korotkov sounds, you can use the auscultatory technique to identify the Korotkov sounds, right? And here you have Korotkov's 1 will correspond to systolic and Korotkov's 5 will correspond to diastolic. Whenever you take the blood pressure, remember that you should take it in both arms at least once. The idea is that usually the dominant arm will have a higher blood pressure, and we always choose the dominant arm because of the increased muscularity. Blood pressure is higher. It's always better to get a higher reading. So we take the higher one, that is usually the dominant or right arm in most individuals. And when you measure the blood pressure using the set technique, do not do it just once, do it twice. Right? Do it at least twice, and the value should not differ by more than 5 millimeters. So the systolic blood pressure, first time I did 120, second time I did, it turns out to be 130. That's too far apart. Now I would want to do that again to make sure I repeatedly get values which are not spread out by more than 5 millimeters. Right? Nowadays, you have a lot of these digital instruments, digital manometers, which use something called oscillometric technique. That is, as they deflate the blood pressure, there are algorithms that can look at the maximum and minimum pressures and they calculate. They are quite accurate. Okay, not very well calibrated machines can measure within 2 to 3 millimeters of what you measure using your auscultatory technique. And these are very important tools, the electronic BP apparatus, for the patient to use at home. So, using these techniques, we will finally say that the patient's blood pressure recorded first time is this much, second time is this much, and this is what you will tell the patient. This is your blood pressure. You're not telling him if he's a hypertensive or not, right? You just tell him, this is your blood pressure. At this point, it is quite natural that the patient would want to know, am I a hypertensive or not? So, very important thing, before you say that the patient is a hypertensive, you need at least 3 readings. You need at least 3 readings, not at the same visit. Okay? Should at least be 1 week apart. You call back the patient, you say, listen, your blood pressure is a little elevated. I would want to look at your blood pressure again. Okay? I would want to look at your blood pressure again before I say whether you are a hypertensive. Usually, what I do from a personal standpoint is that there is a role of looking for organ damage due to hypertension, that is, retinopathy, nephropathy, cardiac involvement. If any of this is there, you can say, yes, this is a hypertensive, right? This patient is a hypertensive. It adds more weightage to your diagnosis that this patient is a hypertensive. So one thing you can do is, suppose you got an elevated blood pressure, and that too it is very mildly elevated. I'll come to what are these stagings, but if it is very mildly elevated, I will tell the patient, okay, it is slightly elevated. Let us see if there is any organ damage. Kindly go back, get a urine analysis for proteinuria, get a serum creatinine, get an ECG, get these investigations and meet me in a week's time. So this means next time when he comes to me, I will already have the investigations that look for organ damage, and at the same time, I will also have a chance to measure his blood pressure again. I will measure the blood pressure using the same technique a second time. And if his blood pressure is elevated for a second time, okay, at least 1 week apart. So I measured once, twice, okay, maybe on the first day, a third time on the second visit, and all 3 times it is elevated. I tell him, yes, you are a hypertensive. Okay, even there, if the patient is having mild hypertension, that is what we call stage 1 hypertension, or just elevated blood pressure, unless there is any organ damage, I will tell him, before I tell you, I conclusively tell you that you have elevated blood pressure, I want you to come back again. I can measure your blood pressure again, because there can be some stresses in life that is transient in increasing this person's blood pressure. Once I diagnose him as hypertension, yes, I might have to start treatment. So remember, if it is a very mild stage, okay, mild elevation, you will always tell him, come back, we can always check it again. You should, however, advise such patients to go for lifestyle modification and dietary modification. We'll come to that, right? So let's look at how we are going to classify hypertension or make a diagnosis of hypertension. Classically, a blood pressure of systolic less than 120 and diastolic less than 80 is considered normal. Okay. Historically, we used to take a blood pressure of more than 140 systolic or a diastolic blood pressure of more than 90 used to be called hypertension. There is a lot of controversy and discussion going on in this field because even though the cutoffs are 140 and by 90, these cutoffs were initially based on research that showed that if you had blood pressure more than 140 by 90, it would lead to long term complications like heart attacks or strokes or kidney failure or a retinopathy. However, it has now been shown that even if you have blood pressure of 130 by, okay, your systolic more than 130 to 139 and your diastolic between 80 to 89, which is not classically what we used to call hypertension. In fact, this group was called pre-hypertension. But it has been shown that if your blood pressure is between 130 to 139, compared to a patient who has blood pressure of less than 130, you have a higher risk of heart attacks and strokes and kidney damage. Right? So, because of this reason, 130 to 139 has been classified as stage 1 hypertension, or 80 to 89 diastolic blood pressure has been classified as stage 1 hypertension. If you look at your older books, you will see that's part called pre-hypertension. Now it is called stage 1 hypertension. And if you have more than 140 systolic or one or more than 90 diastolic, it is called stage 2 hypertension. So what used to be called hypertension earlier, we are now calling that stage 2. What used to be called pre-hypertension, we are already calling it stage 1 hypertension. Okay. And the major reason for that is because it has been found that patients who have stage 1 hypertension also have slightly higher risk of organ damage as compared to the normal. So what's normal? So normal is less than 120 systolic and less than 80 diastolic, right? If yours is between 120 to 130, that is 120 to 129 systolic, and between and less than 80 diastolic, it is then called pre-hypertension or elevated blood pressure. So now the concept of elevated blood pressure, that is not normal but slightly more than, even this group has slightly elevated risk, but not as high as stage 2. So when you're looking at normal 120 by 80, these are the people who have minimal risk of having heart attack, strokes due to hypertension. When you come to elevated, slightly increased risk maybe can be managed by diet and exercise. When we come to stage 1 hypertension, you need to be a little more cautious, you need to be a little more aggressive in your management. Look carefully if there is any sign of organ damage here. Stage 2, clear cut, these patients need medicine.